little introduction. He has done an amazing work for organizing the AIOC 2023. He is the professor and HOD of Amrita Institute of Medical Sciences here at Kochi, and he will be talking on initiation into clinical learning. Dr. Gopal Pillai.
He is one of the senior most professor in Amrita and a fantastic teacher. Apart from being a great dynamic surgeon, he is also a great teacher. So I request Dr. Gopal Pillai,
one million extra.
Dr. Gopal Pillai to please go ahead with his talk on initiation into the clinical learning.
In a fellowship program, we require clinical learning is the most important thing.
Timer.
So, in clinical learning, the person should basically look at analyzing the symptomatology, adding symptoms to symptoms. Like if somebody is coming with a decrease of vision, you will be thinking about one differential diagnosis versus if the patient has decrease of vision with pain, there will be another set of differential diagnosis. And with something else, there will be another. So that is the adding symptoms to symptoms and sign to sign or sign to symptoms and getting your differentials in different age groups is also important. So forming a differential diagnosis and defining the leading and narrowing the differential diagnosis with tailored investigations. This is what has to be done. Finally, the business of medicine would warrant more and more blanket, shotgun investigations. But what is actually required would be tailored investigations after narrowing down the differential diagnosis based on clinical learning. And finally, management and analysis. These are the things we have encompassed. It is the most important part of learning. It is important that the fellow or the postgraduate who is joining the course knows quite well about this. So you have to first come to a differential diagnosis and then do a final diagnosis. Decide on the management plans and risks and benefits about each, and finally take home the best personalized plan. The purpose is to have a proper differential diagnosis and diagnosis investigations. Cost effectiveness is something that we have to look at in our context of our country. Improving the clinical sense, like maybe you can negate certain diagnoses, maybe you can support certain diagnoses. So all this is possible only if you have a proper clinical sense. And planning a management algorithm. See, our country will have a management algorithm which is possible. In some countries which are insurance driven, the insurance decides the management algorithm and you cannot change. So in our mind, the personalized medicine can go into the patient if our clinical learning is good enough. And always we have to do this risk-benefit analysis in our minds. So the principles are, what are we looking for? So that is what we need at the end of the clinical learning, which is we are looking for the final diagnosis or final management options. So epidemiology is a key factor. If one 20-year-old is sitting in front of my OPD versus an 80-year-old is sitting in front of my OPD, I should be thinking differential diagnosis in my differential diagnosis in my mind, and that thought process has to be going. Symptom basically gives us the acute pathology, the pathology, what is happening inside that, and science will give us localization. So to plan tailored investigation, support, confirm, or negate diagnosis, we require tailored investigations. So there has to be an active push back from the fellow or the postgraduate to have active engagement and participation. Here is one thing in which, unless you understand it fully, you will not be able to take it to the next level. So if you do not understand, it is up to the fellow or the PG to ask his mentor. So encouraging students to actively participate in patient care activities and asking questions, because everybody may have different thought processes, different points of views, different perceptions. So they have to actively participate and put their point of view and not say that, what the master says is the only final word. There is nothing like that. There are 100 ways to skin the cat. All of us know it. And we need those children to actually participate in that. Hands-on experience, enhanced learning skill, and a learner-centered approach is what is important. So, many places in postgraduate, when the numbers are less, there are a lot of issues pertaining that. You always have to provide students the opportunities to engage in the real-world patient-based scenarios. But sometimes it may be difficult because some patients may come for a particular doctor with an appointment. But it's important that the patients be provided such opportunities and have them come up with a differential diagnosis after the workup and probably their thought processes, which could be refined further by a mentor. And also, always during your actions, foster empathy, cultural competence, and effective communication skills. And these are very, very important, more important even than the diagnosis nowadays. And that is what is required. And mentorship should be, we have to be supportive, and there has to be trust. And mutual trust is very, very important, especially when you are mentoring for surgery, etc. Like you have to have that trust. The fellow should stop where he feels that further going on will cause some problems. That has to be there. That trust has to be earned. Offer guidance and mentorship, and facilitate the regular feedbacks. Feedbacks are very important. Positive, constructive feedbacks, as well as negative feedbacks, which will help them, get over it, is very important. Reflective practice in self-assessment. It encourages students to reflect on their own clinical experience, how they perceive their own learning, their own strengths and weaknesses, and how they can improve. Critical thinking and self-assessment tools are very important. Theory is a very broad understanding, and practice is a fine art where bringing the theory to the patient in question, and that is where clinical learning comes. Developing clinical skills, critical thinking, and decision-making abilities are very important. It's a slow and steady process. It keeps on increasing. Even we will be improving in our own skills and judgments over a period of time further also. Perseverance is an important thing there, and always you have to have clinical exams to get that. So the key principles are active engagement, authentic patient care experiences, guidance, and reflective practice, as I said. So preparing these students, first of all, we have to give them an orientation, reviewing the patient care protocols, safety and infection, and equipment should be familiarized before they get in. There are some challenges. There is some workload. There will be a lot of patients to be seen in the OPD. You can't give them 15 or 20 minutes to form their differential diagnosis. Time constraints will be there. Limited exposure to certain clinical scenarios which are very rare, and sometimes emotional stress, all those problems will come in. So we have to support them, mentor them. There has to be peer support networks as well, and educational material should be done. To conclude, the most important thing in a fellowship program is to facilitate the learning process, the clinical learning process, and overall the patient as a whole has to be looked at, and tailored investigations and not shotgun approach. There are hard and soft clinical markers. You should differentiate between them, and they will form time to form judgments. Thank you very much.
Thank you, Dr. Gopal. It was a very crisp and nice presentation. My question to Dr. Uni. Dr. Uni, you are having a big private institution, and as we all know, that since it's a training center also, the patients tag us like a teaching institution. So somehow, how do you handle these private patients? If everything goes well, it's okay, because sometimes they double cross-check whether are you operating, they cross-check with the doctors or with the clinicians or the consultants. If everything goes well, it's okay. If something goes wrong, then I have seen certain examples where they go in for the negligence, proving the court case and all of it. So how do you try to balance between training the fellows, make them see this variety of cases, and at the same time also making them feel that, okay, the consultant is fully there with you? How do you try to make this balance?
So what I do is probably a reflection from the place I learned my AIOS. So what we do is that, again, most of our patients are paid patients. So our fellows get to start the workup, see the workup. The patient always has the assurance that they will see a consultant. It never goes from a fellow level. So after the workup, it goes from a consultant level. And then they come to the consultant room to see the patient after we see and we put our points in also. Regarding surgery, I make it a point to always be inside the room when the fellow starts the surgery so that I can take over or talk to the patient if required. And the fellow gets to start only when the drink is over the eye, essentially. So that is one of the most important features of not being able to recognize. And there is a strict no-talk policy inside the theatre. So these are the couple of ways we manage it.
One big question to Dr. Pramod sir. There is a software which is called as iGen software, which is for the ROP kind of thing. It was developed in Canada, and during the COVID times they have developed this software, like where is zone 1, which is zone 3, and they have to undergo these tests, and then it gives you the marks also. So which one you have pointed out right, which one you have pointed out left. So what is the part of the simulation part of the training in the fellowship program? Does it make a difference for the fellows before they see, especially the ROP babies?
Yeah, as far as surgical skills are concerned, or examination, also you talk about ROP, probably that will cut down the learning curve, I will say, shorten the learning curve most time because particularly new simulations are there quite good. Yeah, so definitely like pilots, you can't say I will try on a flight. Simulation is necessary. Similarly, ROP based maybe practical issue is parents are sitting there, most of them are like emotionally involved, and then somebody maybe is crying, and then trainee is examining and struggling, and you come back again and want to examine. They don't want that most of the time. As a parent, I also not like, and that's the role of simulator comes. I think definitely it helps to shorten that. But what so that is the one. But most of the time coming back in these babies when we take for a laser in the OP, that is the time students can have a look at it. But yes, the main purpose is to shorten that curve. But ultimately, finally, whatever simulator is different. When you specifically talk about ROP, how to handle the baby. You have to get over your own that emotional feeling that handling those entire baby fits in your path. Like, so that eventually you have to practice. But yes, because you've already gone through startup simulation and work out on that. Like same thing was you have done enough PRP using indirect laser photocoagulation. That startup back to the simulation when you want to do laser for ROP where you can't see patient is not cooperating. You have to do it. It's one of that. But definitely there is a role for simulators in our practice. But that is not everything. Ultimately it's like
any quick comments from Mahesh sir on the Gopal's presentation?
Nothing, very nice presentation. I would agree with what Pramod said, like simulation is one. It lays the groundwork, but then like subsequently examining the patient or examining our child is totally different. So they still need that experience on it.
So Gopal, one last question. Do you protocolize your training schedule like they have to first see the OPD for first 3 months and then enter into the OT and then start the vitrectomy after 6 months? Do you follow the protocolization?
Fellows are post-MS. So their protocolization will be a little different. I would not want them to just sit in the OPD. Then I would ask them to come to the theatre, definitely. But giving surgical steps and all would be a little slowly. I mean, one step at a time, like that. Once you're comfortable with one, then we'll move on. By the time we'll develop that trust as to whether he will overdo his steps or whether he will be fine with whatever he knows. So then that is a slow thing. Clinical diagnosis, laser, angiogram, all those things are also stepwise. Yeah. So I can think that there is a protocol involved.
Just want to add one more thing was Kunni was talking about. What I do, tell fellows, when they can examine the patient, then I want them to write their plan. Actually, just concise, summarize the entire history, whatever they are going through, 100, 200 pages, some patient carry all those things. And it's 8, 9 sentences, you just narrate, and I tell them as if you present case to me. And write down their diagnosis, their plan of action. So then, but then discussion happens not in front of the patient. We do everything, patient walks out, I correct that one. So, but I know his thought process. So when you write something, your thought process should reflect to that, how exactly so somebody else reads that or whatever is written. We do correct in the So I close up the file only when I do correction. But I insist on they should write. Rather than they just see patient draw something and then you take over. And no nonsense talk in front of patient. Whatever questions, all those things, once patient is out, then we discuss.
Exactly. Very true, very important, because that patient is going to tell others also the same thing what has happened in the OPD. Thank you very much, Dr. Gopal.
I'll try to arrange something for you.
I think
They'll get some documents.
You can just exchange for some time.
No, it's okay. We'll finish the session. Yeah, it is open till 3.
this session will be over by 2:30.
No, sir. We'll finish the session. Yeah. So next I request Dr. Mahesh Shanmugam, sir, the Chairman Scientific Committee of Vitreoretina Society of India, a very dynamic surgeon and a great teacher. I would like to request Mahesh sir to speak on how would I excel as a program director, because of course in India, but in abroad, the program director has a huge role. We aware of it, sir. So definitely, I would like to know more about this on this topic. Over to you, sir.
Thank you. And this is a talk which was given to me I want to excel as a program director. So I don't know why Dr. Chitra asked me to speak on this. Either that will be a good learning experience for me and so that I can improve. Or that I'm already there. I don't think it's checking the situation probably. She expected me to improve further. So, like, look at it from the perspective of the fellows. Like, the fellows look at it as like this: sort of the fellowship is equivalent to budding chances. So that's what they want. But is that what it is? A good fellowship is something which makes a complete physician. Maybe you wear the Raven suits or not, but then it makes you a complete physician. So instead of telling them what I would say as a complete program, because like I will talk about like what we import to our fellows, and then see that kind of makes up the complete program and add up on the things. So I call this the 10 Commandments. I have spoken this earlier in other forums also. One of the as well. I think she was maybe familiar with this. So let's look at the commandments. Number one is thou shalt be familiar with your instruments. Vitreoretina surgery is something which is heavily machine dependent. So an optimal surgical outcome depends on efficient use of equipment. Maybe the microscope, vitrectomy, laser consortium, etc. So unless we know the capabilities and the limitations of a machine, we cannot use them to the optimum and give optimal surgical results. So they ensure that the fellows do read the manuals as well as discuss with the visiting technician about the mechanism of the machine to know the best capability of the machine. Next is thou shalt know your case. So I was doing sclera buckling with under Dr. Chandra supervision, and he told me, made a comment, the cobbler can do better buckling than you. So all my 15 years of doing medicine, and then I thought like, oh my God, this is where I am. I might as well have become a cobbler 15 years back. But then he came up with the subsequent statement, said like the difference between you and the cobbler is actually the way you suture the stitch. The clear buckling and the cobbler, how he uses is pretty much the same. But actually, he does a much better, precise job of placing sutures. The difference is you know when to do a clear buckling versus the cobbler doesn't know when to do a clear buckling, or rather than how to do a clear buckling. So that's what I will try to import to our fellows. So if there is a case which is there for surgery, that like what Mohammed said, we make a plan. So you read the case, like you kind of know this particular patient needs a clear buckle, this patient needs a vitrectomy, this patient needs a complete vitrectomy. So look at the case and formulate a plan. Thought process is very, very important. That's what we try to teach them how to do that. Third is you shall use all your senses to work. So that's like develop the sense of keeping 1 ear on the monitor, 1 ear on the machine. So if the patient wants to have the urge to vitreate and the pulse will go up, and if you're doing a surgery on the GA and you're hooking the muscle and your anesthetist is busy looking at the WhatsApp, you will be the first person to pick up that the patient is going for a bradycardia. So there is music also now, so maybe like you may be the first person to pick up bradycardia. And again, you know what the machine sounds like. So if there is a little change in the note of the machine, you know something is going wrong with the machine. So that's what we train them for. Number 4 is like thou shalt not cover shortcuts. So here is a patient who has dental attachment PVR, and if you don't peel all the membranes and you think silicone oil is the substitute, obviously it is not. And similarly, this patient needs a belt buckle, placed with belt buckle. So don't opt for shortcuts, thinking that silicone oil or not opting for a belt buckle is a solution in a particular case. So despite which the patient may recur, but you go home in the hope that like you've done your best and hoping that it's fine. The patient recurs after that, you know that the disease is just playing forward. Number 5th commandment is thou shalt not bite more than you chew. In the initial stages, what happens is like you tend to take up more complicated patients, and then like we get stuck up. So you're mentally and physically stressed and tired, and the subsequent patients in the list get out the raw end of the stick because they're tired and frustrated. So we should know our capabilities and start off in a great fashion, taking up simpler cases and building upon them rather than start off with the difficult cases and then making them have a negative impact on it. Number 6 is thou shalt not cover the neighbor's equipment. So very often you have the newly minted fellows coming in, joining a place, coming and saying, I want this particular detective machine, that particular laser, this particular microscope. It is not the detective machine or the laser or the ones which give you the benefit or the best surgical outcomes. It's actually the surgeon himself. So it's a marriage between the surgeon and the equipment what you have is what gives the optimal surgical outcome, and not having the best of the equipment or best in the market at that particular point in time. Ultimately, somebody said that the happiest people don't have the best of everything, they just make the best of everything they have. So this happy marriage between the equipment you have and your capabilities is what gives you the best results. And we also focus on the ergonomics. So thou should have long wear life provided you sit right and tight. So the way you sit and the way you operate, like sit erect and make sure that like you operate in a very relaxed way is what makes you a better surgeon. A frustrated surgeon or a surgeon who has a back problem because they sat in a wrong posture is a tired surgeon. So a tired surgeon does not give a proper results, optimal visual, optimal surgical results. But this is something which we focus on in this semester. Commandment number 9. Thou shalt not blame the patient or the disease and take responsibility for your action. This is a very, very important one. So taking responsibility is something which doesn't come easily. So, and in VR it's very easy to say. The patient has a recurrence, you say that like this patient has a recurrence because the disease was bad. So if the PRD was bad, the vitreous hemorrhage was dense, it's very easy to blame. So there are two types of surgeons. One who blames himself for every failure, the other one who blames the disease for every failure, or the patient not maintain position, patient not come on time. So both have their pluses and minuses. The one who blames himself actually is better for the subsequent patients because he goes back, analyzes the surgery, reflects on it, and does a better job the next time. But the one who, and it's good for the subsequent patient, but it's bad for the surgeon because there's a lot of angst. And he kind of tends to blame himself, and that gives rise to a low self-esteem. The other one keeps blaming on the disease, so it's bad for the subsequent patient's office. And so it's best is to walk the thin line between blaming oneself and blaming the disease. So somebody said in China, the Chinese proverb which goes like who blames others has a long way to go on his journey, and who blames himself after that, who blames no one has arrived. Commandment number 9 is thou should empathize with the patient. It's usually a patient say this is a TID patient, this is a vitreous hemorrhage patient, a diabetic patient. It's not that way. It's a 41-year-old single earning member of a family who has got diabetic eye disease with fractured detachment. He's wondering how he's going to support his family in the next few years. So if you note that or a pregnant lady who is blind, like bilaterally blind because she develops this heart. So if you know that aspect of the disease, then you empathize with the patient, and that gives you the best outcome to your patient. So it's the William Oscar who said a good physician treats the disease, great physician treats the patient who has the disease. And commandment number 10 is thou should remain humble. Humble we are surgeon, is a learned surgeon. The moment we think that like we know everything is when you get hit. And other than this, there's one slide which is going off. Yes. And the days of I know it all has gone. So the moment I sit around telling the patient like this is what your diagnosis is, what the treatment is, all my fellows are behind me googling the diagnosis, the calculating the diagnosis to say that if I'm right or wrong. So if you don't know, best is to agree that like I don't know what the disease is, let's find out rather than saying, oh, this is what it is. They know that like you're telling you're putting a fast one and they lose that stick for you. Other than this, yes, like Gopal mentioned, we go to a structured training, then progression. Initially, they do steps in surgery, then they do simple surgery, then they do complex surgery. In the OPD, yes, they can dispose of patients after 6 months of training, but we come in the patient from the beginning and always have a consultant's opinion before they advise a surgery, and we do have regular class and journal classes to take exit exams. So number of surgeries wise, this debate always goes on. This Association of University Professors of Ophthalmology Fellowship Certification Committee in the US has suggested that like they do 100 vitrectomies either by themselves or the supervision at around 20 buckles. At our place, yes, the fellows do around 100 vitrectomies independently. Buckles is a bit of a difficulty. And initially at a consultant supervision, the consultant stands with the OT and supervisors, and subsequently they are able to do the surgery by themselves. And of course, I agree that independent surgery may not be possible every institute. Surgical audit, yes, we have to have dedicated PR classes on surgical cases which have gone wrong. It may be consultant cases as well as fellows cases which we discuss in the class. And the operating fellow will make sure that they see their own post-op as well as we tend to see if they have records. Clinical skills, they do hands-on FFA, ICG, OCT, lasers, RFSD, lasers, and they do workup opening patient. We emphasize saying every patient is a learning opportunity. It may be in the past, in that particular case, something is there to learn from every patient, that's something is the research, yes, they all have to do complete two papers as a primary author, and there are actively reported ongoing studies at present that are work of the VRCAP. But so to summarize, a good fellowship program is not only funding, it should inculcate life values and training in patient care, training and research to make them a complete physician. Thank you very much.
Thank you, sir. Wonderful presentation. Sir, as a program director, now the fellow comes to you for a fellowship interview. He says that, sir, I have already done 10 defectomies in the previous college where they have learned. And I have a good hands-on training. I have done 100 papers. I have done all those good surgery. The other fellow, you see, a very bright student, but not having good surgical exposure at all. So in these cases, usually we tend to select the fellows who are already have a good hands-on experience. And sometimes the chance can be divided to the people who are actually want to learn more, but unfortunately in their previous medical colleges and institutions, they might not have got a chance. So how do you tackle these situations and how do you select these students for the fellowship interview?
See, as far as VR is concerned, we need to see if they are going to speak to VR. If somebody comes and tells me, I am going to do cataract, but if the previous doc, I want to do it, so I go to the fellowship, so he goes down with this. That's so if a person who is dedicated and doing VR is what we select that. And if he has done some cases, some place, then you probably look at the kind of place where they if it's an unsupervised veterinary in a medical college where they don't have a trained VR surgeon, then probably he stands a little less chance as compared to the guy who really wants to do this surgery, but he has not had an exposure. Because if we have this 2 years to train them into doing that. So that's how we look at it. And it's just not what experience they have. And the clinical skills is what we look at, knowledge is what we look at, and the enthusiasm and how badly they want to hear is what I look at.
Lalit sir.
My approach is slightly more aggressive. I will demotivate that person not to be here. The reason being that the same thing actually, I have to derive how much passion or interest. That's what is distracting. So what I'm saying is, I will try to demotivate he or she because I want to know or understand how much he or she wants to be into here. Because if a tertiary fellowship, like you said, patients who know, Mahesh also was saying. So I have to see how much passion there, how much he or he wants to learn. It's not important if he is briefly trained in a couple of techniques or this thing. But if the first category, what you said, if he says that he will stick to it for 3-4 years, and if we are eager, this is example I think of recent interviews what we had in Central Society. So we selected the first category because she is greatly wants to do it. Why demotivate? Because she graph or learning is a long journey, and if she still want to do VR, no, then it's my job to train her and go in
Pramod sir, they have not done any cataract surgeries at all. He's a very nice, or he or she is a very nice surgeon, and they want to do direct VR fellowship. So, what is your thing? You post them for the cataract for 6 months, get a good hands-on training, get a good tissue handling, and then come back to the VR.
Actually, this question is relevant now as a post-COVID era. A lot of people have just not got any hands-on at all. But we also know along with that people have done a lot of surgeries and then realize they're doing a lot of complications, lack the depth perception. Would have done cataract, lacked it. So initially, as a routine protocol, what we do is everybody they go to our spin clinic, go see their perception like hand-eye coordination. I mean, unfortunately, we really surprised that a lot of people, they need a post-graduation, but they do not have proper hand-eye coordination and lack depth of perception. So that is what we, as a routine, as an induction training, before India, they go through this checkup. Yes, and coming back to your question, yes, that unfortunately the problem is because when you want to do VR, you do not have time then to train first to tissue handling, do cataract and all those things as part of curriculum. So it's not fair for them, coming to previous question, but there's no other choice. So probably they can go, get some training done, at least learn how to identify all the cataract, but learn how to handle well, and then come back probably with both more or less similar therapeutically, because that's the way person most of them during implement their experience probably is some way will go, but ultimately how desperate person is. But that we cannot avoid because we are not here to train again from cataract surgery, go up, crash, and then bring them back to here. That your tenure is not adequate enough for that. It doesn't permit. I know it's injustice for the we don't have.
Thank you, sir. We will move on to the.
Any thoughts from the Naresh, sir?
We would like to welcome to this session our AIOS President, Dr. Lalit Verma, sir, Dr. Chitarama Murthy ma'am, and Dr. Naresh Babu sir as the expert panel. Now I would like to welcome our next speaker, Dr. Srinivas Joshi, who is a very brilliant VR surgeon from MM Joshi Eye Hospital, Hooghly, and he will be talking on taking the fellows beyond launching platform. He is also the academic and research committee member from South.
So since Dr. Raja Narayanan is not yet arrived, I think we'll go on and this call. Thank you very much, AIOS, for this opportunity. Thank you, Chitra Madam, for being very passionate in conducting these programs. And thank you all the AIOS office bearers, President Dr. Lalit sir, Amrita Madam, and my colleague, Satyajit Singh AIOS. So taking the fellows and the fellowships beyond time and investment. So it is two perspectives. Looking at the teacher's perspective and looking at the student's perspective. So what are the basic expectations of the fellows? By the end, they should be able to manage the patient of that specialty efficiently. If we are talking about VR, then they should be able to do a nice vitrectomy, a good buckle, should get chances to learn new skills, should get chance to be a part of the research activities, and they should know their competence levels and the limitations. So definitely understanding their needs. Fellows join the course with various different levels of knowledge as we were discussing, and with the personal backgrounds as well. Personalization, my first one. Some points to consider while planning the fellowship program. So I request the fellows who are intending to join for the fellowships can have a formal and informal sessions with their co-fellows or with the fellows in the other institutions to know them better, can plan the approach accordingly and can plan the duration of the fellowships based on the competency. Here is one interesting paper, the consequence of work environment on employees' productivity. How important is the work atmosphere? The behavioral components of office environment have a greater effect on productivity than the physical components alone. Just by giving surgeries, just by asking them to see the patients will not actually, as shown in this paper, it is also the work atmosphere has to be good, and that leads to more productivity was what is beautifully explained in this paper. Planning, the must knows and the must do's of your specialties, the good to knows, the once in a while, and the good to refers. I think these are very, very important because we have seen that some fellows, even though they are not capable of handling further, they sometimes try to gumble up and face more complications, and you should know when it has to be given back and when it has to be referred. The symbiotic association, both the planner and the students should know the responsibilities and the reasonable expectations. So this is a very interesting called the DeFries model. So where a novice surgeon begins, then he becomes an advanced beginner, then he becomes a competent, proficient, and the expert. So So this is the scale, that is the DeFries model of skill acquisition, which is very, very important. And the DeFries, it says that from the novice that you don't know how to do something, and then he comes to the advanced beginner where he's consciously incompetent, then the competency stage where he becomes consciously competent, and then you know how to do something and then you do it perfectly. It's one of the very acquired model, the DeFries model of stage of acquisition, acquiring competencies, and then the lacunae, of course, lack of explicit, because it's a competence-based assessment, focus more on theory rather than the competency. See, this is the traditional versus the CBA. So CBA is nothing but the competency-based education model. The traditional model is the curriculum drives it, because we have a set of curriculum and we have to do exactly as per the curriculum. Whereas the competency-based education model, it says that the health needs or the health systems that drives the curriculum rather than curriculum driving the situation. Attitude, definitely. I'll come to that. Professionalism is one of my favorite topics. Yes, definitely a fellow does a perfect enucleation, a fellow does a perfect vitrectomy surgery, but has the informed consent for enucleation or any other surgeries has been taken? Has he checked that file? Has he looked into it before going in for the surgery? The attitude of that person, I think, fellows, is very, very important, where we need to learn. So this is the ACGME, the current assessment system, where system-based practice, professionalism, interpersonal and communication, practice-based learning and improvement, patient care, medical knowledge. So this is a circle which they have to follow. It's not just doing a good surgery, or not just doing a good diagnosis or a good treatment, or not just a good talking to the patient. It is a complete professionalism which has to be obtained. So again, the knowledge, the skill, the attitude, the overall competency. There's something called as ICO 360-degree assessment tool. Actually, it's very, very interesting, and we can go through that. How the degree of evaluation by the peers, that helps to motivate the person and that helps to improve the personality, because most of the American association have described that 60% of the doctors' violence which is happening is because of miscommunication, and that is what is also important. And now we just got to know the NMC has also included professionalism into their curriculum, which is very, very important. And of course, simulation training, as we just discussed few hours before, wet lab training, dry lab, mannequin, or computer-driven and virtual reality is very, very important. If possible, you get that. But there are certain challenges. I got to know in the GOH in Chennai, they have a good load, but 2.5 crore simulation machine has gone to Tanjavur, where there is less. So what the peers were discussing, or what the teachers were discussing, is if they want, they can send them to Tanjavur to get that, because these simulation machines are very expensive. 2.5 crores or 3 crores for one machine is very, very difficult. So we can have a curriculum where the fellows can be posted there and then they can come back. So that kind of, I think, arrangements they are planning up. And of course, as Mahesh sir said, hand-eye coordination, and Pramod sir also said that hand-eye coordination under the operating microscope. And this is another interesting, that is the Kilpatrick's 4 levels of education evaluation. That is reaction, learning, behavioral changes, and organizational performance. So he has also stated that 80% of the doctors change their behavior is because of the evaluation by the patients and evaluation by the peers. So there are different levels, Kilpatrick's level 1, level 2, and level 3, and level 4. I think we can go ahead and read it more in the books. And the father of professionalism, George Miller, Miller's assessment of pyramid, that is knows how, shows how, and how the student performs. I think this is a very interesting this thing about the professionalism. And of course, become a member of AIOS, you get access to so many journals. There are many new journals added. I don't know, it's a little old slide, but definitely you get access to one network of AIO. Coming to the fellowships abroad and the fellowships Indian. Please believe me, I have completed fellowships in both the areas. I personally believe that fellowship in India definitely gives us more chances, it gives us more surgical exposure. And then if you want to do a further fellowship, and then you can try, because as soon as the MS is getting completed, I have seen many students coming and asking, how to apply for foreign fellowship, how to go in for SF match, how to go in for the Canadian fellowship, how to go for the Australian fellowship. They are more focused on how to do that. But the basic problem our fellows need to know is, first we have to do a fellowship in India, get that confidence, and in case you require just a Western culture and Western taste, if you want to know how they treat the patients or how they talk to the patients, then definitely you can definitely have a chance to go. The short-term fellowships are available. I would like to say that observership is very, very important. If they are not confident that I don't know what I want to do, but I think I want to do VR, then that's not the way. I think for the fellows, the dipstick test before the long-term fellowship is to do a short-term observership. That is very, very important. And then comes the long-term clinical fellowship. You have the various programs running in India and abroad. If you want an abroad, then definitely in America or in Canada, you have to go through USMLE. But there are certain institutions where MLE is also not very compulsory in some parts of North America. Cybersight is another thing that is done by the Orbis. The digital extension of the Orbis mission is a global community of health professionals to learn, share, and practice. So it's also good programs where you can enroll. And the International Council of Ophthalmology Fellowships, they are fully funded, step-by-step process. They have research fellowships. And why should you do a hospital management course? Now, this is a very, very important question. Choosing the right path, private practice, further training. I don't know where that photo went. Yeah. So I just wanted to share that I'm not telling that I have completed that fellowship, but definitely it widened my horizons. When you go out and post fellowship, if you want to do something, if you want to bring your own practice and everything, I think it is better to learn the management terms, because nowadays we are being governed or by the corporate practice, or the corporates are governing us. So if we don't want that to happen, then it's better we learn those management terms so that we can face the situations apart from the curricular program. Whatever we are doing is also to do a good management course if possible, offline or online. Then again, institution practice, private practice, further training, choose the right path, and making the best use of the conferences. So when at a conference, I always request my fellows to set your goals, plan what sessions you want to attend, plan whom you want to meet, and dress appropriately. Then of course, know your technology, update online profiles, record and follow up. I've seen in most of these international conferences, most of the fellows, they come out with the laptops or with the tabs. They just click a photograph and then they start writing the notes there on the slide itself. So that the training will be very easy rather than keeping on writing, and sometimes it goes back to the file and we don't know how to retrieve also. So we need to get updated with the recent technology of how to get back on these. So when at a conference, I always say, visit the trade area to know what's latest and what is trending. It's very, very important to know the cost factors for future planning. And don't be shy, walk up to the leaders. Chance to meet the expert is the best when you are at conferences, and make an impression that will last and improves that chance of fellowships. So my experience, my first presentation was at RedNet, and then I gained up a little more confidence. Then I did a observership at presenting in University of Toronto, where probably a few of my mentors, they got a little bit this thing, and definitely I then appeared for the exams, and it was easy during the interview, and that is how I see here Mahesh sir gave the opportunity, and Pramod sir was also here. And in fact, I have shared this a couple of times with Pramod sir as well. And of course, owning these now, I'm not telling that I have done, but a little bit what I have achieved is all through the small baby steps. So it's always important to do that. And don't attend the conference just because my friend is attending, but it's such a cool place. So such a nice waterfront is there at Borgati. So let's go there, go for walking, let's go for a cruise ride. Of course, you have to make that also. But please complete whatever you want to attend and then go for that. It's all about balance. My last slide is finding the right balance. Of course, with all your curriculum, with all your busy practice, seeing patients, learning and everything. But please remember, having a perfect work-life balance is very, very important. Spending time with your spouses, spending time with your children, and giving time to your family is equally important in the fellowship. And if you ask me, I am not the right person to tell what is the best work-life balance. If anybody is here who would like to comment on that, I'll be really happy to learn from them as well. So thank you very much for the patient listening. Thank you.
Thank you so much, Dr. Srinivas.
You said spending time with spouses. That was dangerous.
Spouse.
So,
Spouse, sir. Sorry.
Dr. Srinivas, coming back to ophthalmology, you said you did your fellowship in India also and abroad. Is there something additional or different you learned in Canada which was not there in the Indian fellowship, which benefited you? Would you like to share your thoughts on that?
No, to be very frank with you, definitely two are different things. You learn something good at India, you learn something good at the Western or the Eastern culture. It's basically how the approach to the patient might be different from surgeon to surgeon. So what I would like to say, when before they jump in directly into their private practice, it is good to see how Dr. Naresh Babu does the surgery, how he talks to the patient, how Dr. Lalit sir does the surgery, how Dr. Prabhu, Dr. Uni or experts, Dr. Mahesh sir is sitting here. It's always good to have a good combination of these and do what is best for you. So I learned that. Some things were good at India, basically the place where I did my fellowship, and then I went abroad. I learned certain things more there also. So it's a good combination you will have. It's not like, okay, some things are good here, some things are bad there. Try to pick what is the best.
In your program at Joshi Eye Hospital, have you had opportunities where a fellow thinks that he can do VR or a cataract, and then 6 months through the program, as a program director, you realize he is good only for cataract, he is good, and then you made him shift or guided him to switch programs?
In fact, I wanted to ask that question to the panel also. Once they join the fellowship, do you have any curriculum assessment where they do it? Because I had that during my fellowship at Toronto, where after every 3 months I would be assessed. They would give a big sheet, and my professor would have that, and he used to tick all those. It was nearly 3 pages, and then it used to go to the program director, from the program director to the university head. And if we had scored less, I have seen some fellows being sent back. Not many, but some fellows being sent back. So, is there any curriculum that we do in India where we try to assess the fellows every 3 months? Because
in India, anybody who joins the fellowship program completes it and comes out.
No, actually it was there initially. When you started initially fellowship, the same thing. 4 fellows used to join, every 3 months one will go home. Who is the worst in the lot? That's the way it started actually. But then everybody is on their toes. Okay, and if they are good, they are good. Yes. Now the fellowship you join, we want to finish because most of them are not attached to university. We try to introduce examination pattern, curriculum, all those things. But after evaluation, suppose he doesn't do well, are you going to send home? Your answer is yes, then continue that. If no, then whole exercise goes well.
so telling the certification, I would shift them to the cataract surgery, do a good cataract surgery, and come back to the department.
All of us had this system in mind, whether in writing or not, does it even matter. You see, the mentor keeps us assessing. Like there was like we had a technical protocol school, and in the mind we assess A, B, C, or excelling, not excelling, writing papers, assisting, studying in machine before everyone, like cutting is not studying class.
I have a question for you.
Graded program.
I want to ask you that to your fellows, especially in this subspecialty, would you feel that fellowship is enough, or they should continue to work for a couple of years more before they go out into the world for a practice? Like in a cataract refractive, the fellowship period is enough for them to go out to work.
I think nowadays most of the VR fellowship is now 2 years, 2.5 years, and some places it is 3 years. I think they really get a good exposure in that 2.5 and 3 years and 2 years. Of course, it all based on their competency. If they can do a good PVR surgery or a good PDR surgery with the membranes, I think he's good enough to go rather than staying here. If he's still not confident, if he's still not confident of doing the complicated surgeries or even the medium complex surgeries, then I think it is better for him to spend little more time, either like a registrar or a junior consultant. He can join the institution or whichever allows it if there is a vacancy. And then once he gets the good confidence, then he can definitely fly.
Now in cornea and all, they have a DSEC course and dark course and all that. Do they have such refresher courses in retina also?
Refresher
Refresher courses
I don't know because majority of the institutions don't follow the short-term fellowships. Like they come, like if
Retina, I can be short observer in various places just to pick up new senses, but how he is excelling more than me. So that short-term observership is okay. But really short-term, this such courses for a fellow or a newcomer, they are not working. They are not working.
Over a period of years.
There's nothing. What I believe is
so it's all based on your personal relationship with that person, and you can offer to give him service.
What I see is a passion. If suppose somebody is lacking behind or somebody excelling more, does not mean that I throw her out. So maybe I need to spend more time with her, and see her driving a passion. See, I will put example. One fellow she requires some more. 5 figures are not equal. So you can't have absolute rule of the book. ये है एक विकल्प वो नहीं है.
I'd like to request Dr. Naresh Babu sir to share his thoughts on it.
So, like Srinivas, you were saying about the difference in the foreign and the Indian. One thing I have learned observing there is in my medical college, and I think JJ Medical College in Mumbai also, the motto is mens sana in corpore sano, sound mind in the sound body, which is never emphasized in any of the. So we all ask the patient to go for a good physical activity, the patient is a diabetic. How many of us are doing it? So that I have learned a lot because especially in Canada, I don't find any of them obese actually. Everybody running on the road. Somehow, those sort of the extracurricular things are not emphasized in our fellowship programs.
Mahesh Sharma sir, you want to share it?
For the short term, yes, some of the institutions do give like something a year of billing a backup or something that they were giving a paid fellowship of short term year. Yes, some institutions not as, but usually for people from abroad, they do have that short term thing in India.
Yeah.
But the issue with VR is it's not like a decent, it's like a mechanical, repetitive process, but like each case in VR is different. So you cannot have a short term thing to say that like you can sclerotomy placement and vitrectomy you can do, but then subsequent steps is something which you would have learned. And then no fellowship is adequate enough to make a completely constant VR. So you have to subsequently build up on whatever the basic foundation is given in VR fellowship.
We'd like to
Exactly. Treatment is too wide, so you can't have a repeatable exactly what I wanted.
go ahead.
Yeah, I'm from Arvind Coimbatore. Alcon has started this refresher course.
Okay.
1 week. I think even Madurai they are having. So Alcon sends one week the candidates to come there and be in the OR. You don't give them, but they can observe. And they see a variety of surgeries for the latest one, the cutting edge ones also. So the refresher course is happening even in retina right now. At least Alcon has taken the initiative.
I think the refresher course is more for observation.
Okay.
What Adam was telling is hands-on refresher.
No, that's exactly what I wanted to add on. The refresher was basically when we are in practice, you know exactly where you lag. Note down your point and you identify a person who does those specifically and specialize in that course. But that was when you go in this point, those things probably where you're lagging, you know exactly where the problem. Then you come back. But probably hands-on say, hey, I don't feel enough for you to allow that for 1 week to come and do everything.
Thank you, sir. We would like to bring
Dr. Uni?
Dr. Mani.
One thing we do, we have a 3-month assessment period. So any person who it cannot simply do that certificate on the content to the slight value for that time.
That's a good idea.
If we find that they simply take them through the 2 years. So that is in the admission process. It's a bit harsh, but it's fair, just in the last one.
Because most of them they try to impress during the interviews. Although they have a good theoretical knowledge, they clear the theory and they do that. That's why they say that first impression might not always be the best impression. So once we try going on with them, I think we get to know more about it. So any other comments, any other questions, we can take it. Otherwise, we can.
For paucity of time, we'll end this session here. We'd like to thank Dr. Naresh Babu sir, Dr. Mahesh Shanmugam sir, Dr. Pramod Vedya sir, Dr. Uni Krishnan and Dr. Chitra Ramamurthy for this session. Special thanks to Dr. Srinivas Joshi for moderating the session so well.